Well, here he is, Papa Him. Papa Him, welcome to Healthcare Unfiltered. You are a frequent guest, and we are always appreciative of you being on. So, Aaron, just really briefly for folks who don't know you, which I don't really think anybody on Twitter doesn't know you, but as you know, my podcast reaches people who are not on Twitter, and Twitter is not the real world, Papa.
This is true, and your podcast is expanding. So many new listeners. So,
Fast. So, who are you?
yeah,
Introduce yourself.
I'm a physician, a bone marrow transplant hematologist at the University of California, San Diego, and I treat all sorts of blood cancers and do transplant. And I'm interested in education also. Do a lot of education.
I have to admit that I love your educational tweets. I am ashamed to say that I don't answer all of them because sometimes I don't know the answers. And you do have some difficult questions. These Beatles questions were not easy.
I thought those were good. Some people do them.
Yeah. Okay. So what me and you talked about is we're going to have like this fun episode about, a year in review, a year in hematology review. And I'm trying to think when we would air this. We are taping this on January 9th, but I'm trying to see when we air it, probably sometime in February or something. But anyway, so a year in review, the idea is let's try to focus on maybe, I don't know, top 5 to 10 data points or abstracts or papers that really caught your attention that had some practical implications in the world of hematology. You are into education, so I wanted to picture yourself that you are tasked by giving grand round presentations on top advances in hematology in 2021, and the audience are fellows of hematology nationwide. So you really want to teach them what you heard. Make sense?
Yeah, I mean, I got to think about these. Hold on.
Let's start with one. Go ahead.
What?
Let's do. I'll throw you one. The CAR T data that we have at last ASH. What do you think of that?
Yeah, so there were 3 studies for CAR T cells. There were numerous CAR T studies, but there were 3 very important ones. They were the first randomized studies with CAR T cells. They were all for large cell lymphoma, and they were all directed towards CD19 was the target. It was with the 3 products: liso-cel, axi-cel, and tisa-cel. And they all looked at generally the same patient population, which was patients who at first relapse. So they got their chemoimmunotherapy, R-CHOP, and then they either were refractory to that chemoimmunotherapy or relapsed within 1 year. And it was the same population in all 3 studies, roughly. And this is different from what the label is for these products, which is relapse after 2 therapies or autologous stem cell transplant. So first, what's I think just an amazing advancement is that we could do a randomized study with CAR T cells, which was felt to be not super practical or very hard to do. So we were able to do it, which is great. But we clearly saw some of the issues with running these studies. And so 2 of the studies, one with liso-cel and one with axi-cel. The axi-cel one is Zuma 7, published in the New England Journal of Medicine, showed a benefit in terms of event-free survival with the CAR T as opposed to going to salvage chemotherapy and autologous transplant, while the tisa-cel paper, which is also published in the New England Journal of Medicine at the same, edition, and was a negative study, which showed no benefit going straight to CAR T. So it kind of leaves me and I think the other physicians, especially someone like me who does both CAR T and transplants, at odds of what to do with these patients. I think what's the endpoints were similar, but what they called events were slightly different. And in some of the studies they allowed bridging therapy, while in other studies they did not allow bridging therapy. The patients were slightly different. So I don't think we have a true answer, but what I can say is, what is Papa going to do with this information? Well, what I'm going to do is, if someone is refractory to a chemoimmunotherapy, truly blowing through R-CHOP, I am going to try to take them to CAR T cell, and assuming that we get the approval for this. And most of the patients, at least in my hands, they're treated by the community physician and they're refractory. So then they get referred to me. Well, by the time I see them, it's usually a few weeks later. from that initial time of them being refractory to their chemoimmunotherapy. And then I say, okay, I think you need a CAR T cell. Well, then they got to go through this gauntlet of stuff. And for those who don't know, this process is similar to our autologous or allogeneic transplant evaluation, where they need to have psychosocial support. They need to have a living situation within 60 miles of the cellular therapy center, good organ function, so echo, PFTs, and these things don't happen overnight. So by the time you do all that and say they're fit for it, and then collect the CAR Ts and give them, it's usually about 8 sometimes to 12 weeks from when they were first refractory to the chemoimmunotherapy. Okay. So at least in my hands, most patients need bridging therapy. And when I say bridging therapy, that is some sort of chemo, steroids, or novel agent to keep them in some sort of, without letting their lymphoma blow up, so they're still a candidate for the CAR T cell. So Zuma-7 didn't allow that, while the liso-cel study did. But they're going to get bridging therapy. And I suspect most patients who get bridging therapy prior to CAR T will not have anything better than stable disease, maybe the occasional partial response. And those patients, I will take the CAR T because they do seem to do better than auto. But for those patients who achieve a CR to bridging therapy, well, they're which is rare. It's going to be very rare where you're going to see a primary refractory lymphoma then get a CR to GemOx or whatever you do as bridging, but it's not impossible. Those patients I would maybe then still consider for autologous transplant. Granted, I know I'm going against the study, but just because you only have so many bullets to kill this disease, and that's their time where they can still maybe benefit from auto. And I would.
So if you decide you want to do CAR T though, which product will you use? I mean, technically you've got right. I mean, so I think you mentioned CAR T in general terms as a modality, but let's assume you've got the 3 products approved for that indication, and they are. I mean, they are for relapse refractory after 2 therapies, after
Yes.
2 treatments. You're right. I mean, the on-label is not yet for this particular indication, but let's say it is for the 3 products. Which one would you use? Liso-cel, axi-cel, or?
Yeah, T-cell won't, because the study failed. Okay.
Right.
That's a study that allowed bridging therapy. They actually allowed multiple rounds of bridging therapy in that study. The axi-cel, I would use axi-cel just because the manuscript's there and has the longest follow-up right now. And if you look at the axi-cel data and the liso-cel data that's earlier, the overall survival curves are starting to split. So I'm hopeful that we will see an overall survival advantage. So, there's a bias to this also. Our center, oncologists use what they're comfortable with, and our center was part of the original Zuma. We were part of the Zuma studies, and that's the product I've used the most of. I'm just comfortable with it. I know what to expect. And granted, there does seem to be maybe more toxicity with axi-cel as opposed to liso-cel or the other product, but that's what we're comfortable with. So I would use that.
Hey, Aaron, how do you think they were able to get by without bridging therapy with Zuma-7?
Well, that's the whole point. They had to have used better patients, and they didn't. If you look, I didn't look at the study right before we talked to it, so I don't remember the exact details. But there weren't a huge amount that were consented and then didn't go on to proceed to their therapy. Intention to treat. They most made it so it was a better it had to be a better population than what I'm seeing, because my patients. Well, there's 2 possibilities. Either I'm too fast to use bridging therapy and maybe they don't need bridging therapy and I get too scared too fast, or the patient population was just better. And I suspect it's the latter, because I know what I've seen, and I've seen even patients with bridging therapy who have explosive lymphoma still don't make it to CAR T. But the liso-cel study, they did allow bridging therapy, and that study, I presume, were then sicker patients. But again, we don't have the publication yet. So.
And the way I was thinking as you're talking in terms of structuring the remainder of the podcast, we'll go over disease entities: lymphoma, leukemia, BMT, blah blah blah. I think the myeloma and all that. This way, I think we can think through this. So in lymphoma as well, this is CAR T. There was also the POLARIX trial that got a lot of attention at ASH and so on, and then was subsequently published in the New England Journal of Medicine also. What's your take on POLARIX?
Yeah. So, and again, just because I hope we have fellows and trainees and people interested, let's just go over the, because a lot changed for DLBCL. So the general schema of diffuse large B-cell lymphoma, you have a standard fit diffuse large B-cell lymphoma patient, non-double hit. They get R-CHOP is the standard of care, which it has been since I've been an oncologist. And before that, CHOP was the standard for forever until finally rituximab showed a benefit. For those patients who achieve a remission, they stay in remission and you're done with therapy. For those patients who relapse, if they're fit, the standard of care was salvage chemoimmunotherapy like rice, RGDP. And then if chemosensitive, PR or CR, they would go on to autologous transplant, and we would cure 20 to 40% of those patients. And as we just talked about with the CAR T cell data, that may change. We now use CAR T products for those primary refractory or for the patients who've relapsed within 1 year. And then for those patients who relapse after autologous transplant, they should get a CAR T if they have not already. Or if they're not fit or candidates, there's all these now novel agents like polatuzumab vedotin combined with BR, loncastuximab, CD19 directed antibody drug conjugate. And there's selinexor, which I 1000% don't recommend using. Okay, so that's our schema for diffuse large B-cell lymphoma. So the POLARIX study, is this practice changing? For me, well, we'll get to the punchline at the end. I don't want to spoil it. So POLARIX was it was a good randomized study done at many centers. And they randomized to R-CHOP or polatuzumab plus CHP. So they got rid of the vincristine. That's a fair study. It was a 4 versus 4. They swapped. So they're adding the novel agent polatuzumab vedotin, which is a monoclonal to CD79B attached to vedotin, a microtubule inhibitor. So that's fair. It's not like myeloma or 4 versus 3 or what, I like that they got rid of, and they got rid of the vincristine because of the overlapping toxicities of neuropathy. And so they asked the question, their primary endpoint was PFS. And they included mainly stage 3 to 4 patients, although it wasn't a pure advanced stage study. Roughly 10% were early stage disease, which I find peculiar in this setting, and why they did that, I don't know. And maybe that interferes with results, but they did 10%. They allowed double expressor, double hit, but there weren't many double hits. There were a reasonable amount of double expressors. And a polatuzumab combination won. And when I say one, it won in the primary endpoint of PFS, but like the absolute benefit was like 5% or 5 to 6%. And that's real follow-up of about 2 years. We don't have an overall survival benefit yet, but it's still early follow-up. So not groundbreaking, but it's the first study in a while to show a benefit versus the king R-CHOP. And then toxicity was fairly identical, although you got to use GCSF with the polatuzumab. There was more febrile neutropenia numerically, but not statistically. Neuropathy was the same. And then, of course, polatuzumab vedotin is like a crap ton more expensive than vincristine. Okay. So as my friend Chris Booth would say, who up in Canada, this is a marginal benefit, but it is a benefit, but a marginal. I don't think anyone could say that this is a game changer. This is the thing, the bee's knees for diffuse large B-cell lymphoma. It's a marginal benefit at a magnificent cost. Now, as an oncologist, I have no control over the cost I don't control that, but I do have control over how much I prescribe it. I can control that quite a bit. So I'm torn because I really actually don't want to change because I don't think it's worth it. And at this point, that being said, I haven't encountered it yet. Fortunately or unfortunately, how you look at it, the majority of patients I see with diffuse large B-cell lymphoma are the relapse setting because that's who makes it to the transplanter and the cellular therapist. But I do see frontline patients, and I don't know. I mean, I'll of course go over the data with them, but I can imagine when I go over this data with my patients that the two options now are R-CHOP polatuzumab plus CHP, and this one was better. There was less relapse, not more CR, but the PFS was longer. Of course, they're going to say, why wouldn't I want that? And then I'm not paying the price. My insurance is going to cover it. And I don't know if I can give them, I don't know. What would you say to your patient, Shadi? I mean, they're going to say, why wouldn't I want the best therapy? Even if it's only marginally benefit, it's no more toxic. And I think at that point, I'll probably have to offer it. That being said, I was hoping that the Moores Cancer Center formulary just wouldn't put this on formulary for the front line. Say we're just not. I think that's the way that we could do it. Us as a community, if we all said together, we're not accepting this for this price, for this benefit, then it would be easier. But we're going to accept it.
I think for me, when I look at this, Aaron, I always think the way I would approach this is. It is very clear that when the study was designed, the folks that designed the study and the investigators and the institutions have all collectively believed, rightfully or wrongfully, that an improvement in progression-free survival is sufficient. In other words, I'm sure they had this conversation and they said, what is the primary endpoint that will really be meaningful for us? And they've agreed that it's PFS. Now, it's a completely different podcast, PFS versus overall survival for DLBCL. And I agree with you. I mean, I actually, I believe OS is very important in a curable entity in general to change standard of care. But somehow when the trial was designed, PFS was the primary endpoint. So I think for all practical purposes, the study met its primary endpoint, and it's a positive study. There's no question about it. So, but positive is very small positive. It's about 6% improvement in PFS. Whether this will translate into improvement in overall survival or not, I think it's yet to be determined. And I think we'll probably have to wait another 1 to 2 years to see if there's a difference. Plus, you have to account for post-progression therapies, which I believe might neutralize things, especially that the benefit is so small, like 6% PFS difference. So I think it's going to be probably the only data that we will have. I actually don't think we're going to have an OS difference, because I think when it's only 6% and post-progression therapy is probably going to neutralize some advantage. What I believe is going to happen is that folks at various institutions will have almost an algorithm. I think they will say, these are the patients that I will actually treat with POLA versus not. And I think you'll be surprised. I believe that the field within a couple of years will move completely towards polatuzumab. That's my prediction.
I agree. I will say that, yeah, we agreed PFS was the endpoint, and this is a whole nother podcast, but clearly the drug company, right, it's Genentech, would much prefer PFS as the endpoint, as it's easier to show. And unfortunately, or fortunately for the drug company, the FDA is going to be okay with that. So, and then the investigators are handed this company-sponsored study. They can't say change the primary endpoint. I mean, I guess if they all did, but that's not going to happen. So we just have all become okay with this. And again, I think that's a greater issue that's beyond the scope of this talk. And I agree, it's going to be, but to be honest, I kind of ask myself what I want polatuzumab. I don't really. I guess I don't know. I couldn't care either way if I got R-CHOP or POLA, because that's how much I don't think it helps that much. But you're right, it was a positive study, and it's been forever to get a positive study in this. And again, I think it was a well done study. I don't really have anything critical to say of the study. And for that reason, I think, and what I said when I have my patients, it's going to be tough to not give that regimen. Papa he will probably give that regimen. Yeah.
Let's stick with non-Hodgkin lymphoma in 20. And the way I want to. Like in 2022, are you going to do anything different in 2022 for patients with non-Hodgkin lymphoma that you did not do in 2021? That's how we're framing this. Anything else in non-Hodgkin lymphoma that was
I'll do differently?
Like anything in terms of, if you look at a year in review, anything you in 2021 that emerged that might change how you would treat patients with non-Hodgkin lymphoma?
Not dramatically. I will, some of the, and I know you're not, in PTCL, which is one of my interests, and then a little education. I like teaching. We don't see a lot of PTCL. So, 10% of non-Hodgkin's lymphomas in the United States, and there's many different flavors, but the main flavors are PTCL NOS, which is basically pathologists doesn't know which one to call it, and they just call it that. Anaplastic large cell lymphoma, either ALK positive or negative. Angioimmunoblastic T-cell lymphoma. Those are the main ones. What happened 2 years ago was that they did CHOP versus BV plus brentuximab plus CHP, and that was for CD30 positive peripheral T-cell lymphomas, and they had to express 10% or more CD30. Just like the polatuzumab study, they got rid of vincristine because of the overlapping toxicities of brentuximab vedotin and vincristine. So again, another fair study. They swapped out a drug, granted way more expensive, and the study was positive for both PFS and overall survival. Like that's like a landmark thing for peripheral T-cell lymphoma and overall survival advantage. And so I largely adopted that regimen. Now, the details, though, are 70% of the patients enrolled in that study were ALK or anaplastic large cell lymphoma, which are uniformly CD30 positive. So really, it's a study of that and very few of the other groups. And the longer-term follow-up showed that in subgroups like angioimmunoblastic and PTCL-NOS, that regimen, I know it's subgroup, but really didn't seem to do much, and if maybe even hurt those patients. And given that this is, and it makes sense, those don't usually express a huge amount of CD30, and you know, those patients, I'm probably still going to use CHOP, especially the angioimmunoblastics or CHOP plus a topicide. So that is a slight change in how I do with PTCL. And I'm trying to think of the other thing. It's a little bit of a unicorn disease. There's Waldenstrom's macroglobulinemia, so lymphoplasmacytic lymphoma, which is an indolent non-Hodgkin's lymphoma. But what's unique about the entity, it's right before those lymphocytes. They're about to become plasma cells, but they just haven't yet committed. So they're lymphoplasmacytic cells. And if you think back to lymph node biology, when the lymphocytes undergo class switching, they're all IgMs to begin with, and then they switch to IgG, AA, or all the other ones. So the lymphoplasmacytic cells, they're all stuck in the IgM phase. And with Waldenstrom's, you get secretion of IgM. So and it's a paraneoplastic syndrome with LPL. The IgM's a pentamer, so you see all these unique things with the IgM, hyperviscosity, and then IgM itself so it's a cool little unique syndrome that can have quite a bit of morbidity, even though it's an indolent lymphoma. I'm still treating those patients fit with bendamustine, rituximab, but there's now been at relapse or in patients who are not fit for chemoimmunotherapy, I have been using ibrutinib plus rituximab. And the long-term data of that came out, and it's quite remarkable that more than half had still not progressed at greater than 5 years with rituximab and ibrutinib. And in CLL, which is a disease I do not treat, but there was a randomized study with acalabrutinib versus ibrutinib, and it showed they worked the same, and that there was less toxicity with the acalabrutinib, less atrial fibrillation, less bleeding. And so I've now adopted acalabrutinib as my BTK of choice for indolent lymphomas, and it's been studied in Waldenstrom's, and I feel fairly confident that it's just as effective, and it does have less atrial fibrillation, which can be quite. So I've changed my practice that way. So that was just a little thing, but I wanted to share that nugget.
You want to talk anything about Hodgkin? Have you seen anything about Hodgkin? Oh, by the way, before we move to Hodgkin, how could we not talk about intrathecal prophylaxis for CNS or DLBCL? I mean, my goodness. I don't know. I mean, at the last ASH meeting, I felt this was like the nail in the coffin of CNS prophylaxis. And then Matt Wilson just published that in Blood.
Yeah. So, well, Matt Wilson, who I love, a great guy, great colleague from the other side of the pond. We had a nice little debate on this podcast.
Yeah.
I'm just going to say, I'm going to brag. I was right. Basically, he was for intrathecal and I was against intrathecal. And I always find, and at the time, the data wasn't as much as we have now, but I always say when the data on an intervention is widely discrepant, then what I can usually say with fairly much high confidence, either it does crap, or if it does anything, it's super, 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 super tiny benefit. Okay. So that's what I can always tell my patients. I go, this most likely does nothing. And if it does anything, it does very, very little to help you. But I can always say when you add an intervention like intrathecal chemotherapy or high-dose methotrexate, both which are very unpleasant experiences. I mean, I don't want to get lumbar punctures. I don't want to get hospitalized for high-dose methotrexate and get mucositis. I can say with 100% certainty that those are toxic and a pain in the butt for patients. Okay, so I was uniformly against intrathecal or high-dose methotrexate to prevent CNS prophylaxis in all comers. And I will say that when I was a fellow and a first year attending, I gave it to everyone. That's what I did because that's how I was trained. That is something I independently came to the conclusion that I was hurting my patients. So for me, it was an easy decision, but most of the lymphoma diehards had hung on to that because relapsing in the brain really kind of sucks. I mean, it's a dismal event, and most patients succumb from that, and it's catastrophic. So, and when we have patients with high risk of CNS relapse, which we have many different scoring systems, but the most famous is the CNS IPI. So poor, a high IPI at baseline, a lot of extranodal disease of the kidneys and adrenals. Those are all risk factors. And if you get all the points, you're 10% risk. So that was deemed high risk of CNS relapse. And most physicians would say, well, in that group, they got a pretty good chance of this coming back. Let's still do it, even though I acknowledge the limitations of the data. So now at ASH, and I don't want to quote all the little details, but the bottom line is 2 huge studies. The best data we're going to get, because they'll never do a randomized study, although they can, but they won't. And now I don't even think they have to. I wouldn't even enroll in the study. So one looked at intercalated high-dose methotrexate versus end of treatment high-dose methotrexate. And when I say intercalated, that means giving it on day 14, as opposed to end of treatment as they complete their primary R-CHOP and they get it at the end. And it showed no difference. And the belief was that intercalated is important because you want to hit it hard at first, and that's where you're going to get your relapses. And it showed no difference, and it showed more toxicity with intercalated, more delays, mucositis, and all these things. And one can say that one interpretation of that data could say that, well, okay, you just need to give it, but you can give it at the end. But the more correct interpretation of that data and more likely scenario is that it doesn't work at all. So that's why they worked. There was no difference in working. You give it sooner, you just cause more toxicity. And then the second study basically was another huge retrospective study. And they had a lot of high-risk patients in both the intervention arm where they got a CNS prophylaxis and where they did not. The highest numbers we will get, and there was 0 difference between the two. So I think that puts the nail in the coffin. It secures it for me. And even I've now talked to doctors like Matt Wilson and that group, and I think they're changing their policies. Yeah. I think where there's still some debate and we'll never have the answer, and I have yet encountered this scenario yet, although I have posted this question on Twitter, a testicular lymphoma. And we all know that they have a high risk. And there was the JCO phase 2 paper where they did R-CHOP, 4 intrathecal methotrexates, and they radiated the contralateral testy. And that seemed to result in good outcomes, granted phase 2. And so based off that, I had been following that protocol, but and now I don't know if it's helping. And I also don't even know if radiating the contralateral, I wouldn't want my contralateral testicle radiated. I'm not trying to be fun. These are big deal interventions. So I only see one of those kinds of patients every 3 years. So I don't know how I'll address it. But again, my standard of care is for sure changed or secured with no CNS prophylaxis. Testicular lymphoma is still an area of debate, and I don't know how I'll approach that yet.
So in the world of BMT, since you do a lot of BMT, in fact, you're on the inpatient service right now, I believe.
Right now, I got pulled, yeah.
Yeah, you got pulled. That's what happens. See, if you had COVID, you wouldn't be pulled. In the world of BMT, anything new in the world of BMT over in 2021?
In BMT, okay. Oh, my girls are interrupting. Hi, girls, I'm on a thingy. I love you. Okay.
I love this healthcare unfiltered. We do.
Oh, my wife's walking up here.
Okay, perfect. We can have her on the podcast as well. She probably have.
My infant's naked, so she's granted she's under, but I was going to show.
Probably not a good idea.
Yes, you're sneaking by. Yes, yeah. In the world of bone marrow transplant.
In the world of bone marrow transplant.
Oh God, you're really
Hey, it's your world, Papa.
I know. It is my world. Well, I do everything, so it's a good amount of my world. There is now a lot of data with for GVHD prophylaxis with abatacept, which this is pretty esoteric, I guess, if you don't do BMT. But abatacept, I like abatacept. It's a cool. I think most of the oncologists are familiar with ipilimumab, right? So ipilimumab, which is approved in melanoma, right? And I don't know if it's approved in other diseases. I don't do solid, but ipilimumab basically blocks CTLA-4. So it inhibits the checkpoint and allows the T cells to go kill the cancer, okay? Now, if we had a patient, we were trying to prevent graft-versus-host disease, which is preventing T cells from becoming alloreactive donor T cells becoming alloreactive versus the recipients, so skin, gut, liver for acute GVHD, why would we want to give something like ipilimumab? We wouldn't. That would do the opposite. That would heighten GVHD. Abatacept is the opposite of ipilimumab. It basically activates CTLA4, so it downregulates that pathway. And combined with standard prophylaxis, it does decrease the rate of GVHD. So we are largely probably going to start using more of that. And we're running actually a randomized study that is looking great. I can't comment on it, and other centers are too, where we are getting rid of standard calcineurin graft versus host disease prophylaxis, so tacro, cyclosporin, which are very effective, but have quite a bit of toxicity and are kind of a pain in the butt. You got to check levels, they interact, they hurt the kidneys. They're really not the best. They prevent GVHD, but they're not the best medicines. So groups have been looking at replacing that with post-transplant cyclophosphamide, but it looks like post-transplant cyclophosphamide on its own without the tacrolimus isn't enough. But we have a study, a randomized study, where we're giving abatacept and the post-transplant Cy, and then no calcineurin methotrexate. And my hope is that these studies are positive, and then we'll completely change our way we do GVHD study without calcineurin inhibitors anymore. So that we're not there yet, but I think we are in the era where we're going to start adding a lot of abatacept to our graft versus host disease prophylaxis. So that's really the there was another, this was a study, and I've gotten some heat from my transplant colleagues for this, because I've said this many times. The hardest decision I get as a transplanter. So let's do some more learning. Let's take acute myeloid leukemia. Okay. And so AML, if you have good risk AML, now there's nothing is good risk, but favorable risk, excuse me. The standard of care is chemo 7+3 plus or minus gemtuzumab. And if you achieve a CR, you do not go to allogeneic transplant. You get consolidation therapy with high-dose Ara-C. In studies, roughly 60% are cured. I always tell my patients we subtract 10% from the study, so roughly 50% are cured. Okay, that's an easy decision for me. When you have good risk AML or favorable risk, I do 7+3 plus consolidation therapy, and I reserve allogeneic transplant should they relapse. If you have poor risk disease, unfavorable risk, so complex cytogenetics and antecedent myelodysplastic syndrome, therapy related, TP53, the treatment's actually fairly straightforward too. It's either chemotherapy if they're fit, and usually those patients are Vyxeos candidates, so liposomal, which was shown to be better compared to 7+3 in that population, although there's some issues with that randomized study that I won't get into, or if they're not fit, or some AML doctors will use venetoclax plus azacitidine for those really complex karyotypes TP53 that are unlikely to respond to chemotherapy. Those patients, the decision's easy. They should all go to allogeneic transplant. Although their outcomes are still not so great with allogeneic transplant, roughly 20 to 30% long-term survival, it's not zero. I'm fairly confident if you have complex karyotype AML or unfavorable risk, the long-term survival is zero. You're not curing any of those patients. It's the intermediate risk AML, which has always been the hardest decision for me as a transplanter, beyond belief, the hardest. And when I say intermediate risk AML, for this discussion, we'll just keep it, not to get into the diehards of AML, normal karyotype AML without FLT3. Let's exclude the FLT3 for this discussion. That's a whole nother beef. With those patients, we don't know what to do. And if you look at the NCCN, it says give chemo. And then it says high-dose Ara-C or allogeneic transplant. It leaves it up to the user, okay? And the meta-analysis.
Is it possible because you may not have a donor? I mean, is it like possible?
Yeah. So clearly, but now I will say for those who haven't done transplant, we have a donor now for everyone, basically. Just about everyone has a haplo donor, which you can use. A sibling is got a good chance of being a haplo, and all kids are going to be haplo, and parents will be haplo. So in that umbilical cord, so it's very rare now where I don't have a donor for anyone. And now you can even use mismatched with post-transplant Cy. There's data that you can do that, and it can be safely done. So that argument's not as big of a deal anymore. So we usually have donors for everyone. And so the debate becomes whether you consolidate them or you give them a consolidation with allogeneic transplant. And we have we didn't have any randomized data for that. And we had meta-analysis of studies that basically allocated, it was a genetic randomization. So if they had a donor, like a sibling, they went to transplant. If they didn't, they then went to consolidation. Those studies are okay, but there's some biases that are introduced because of that. Well, maybe if you have a donor, and you can find that maybe you're inherently just better risk because of that. You have more support. There's all these things that go into it. You don't know so it's not true randomized study. And the meta-analysis of that data showed maybe a 10%, 15% benefit of doing allogeneic transplant, but it wasn't concrete. And allogeneic transplants, it's not like CNS prophylaxis, right? I mean, CNS prophylaxis, as I said, is uncomfortable and unpleasant, but it's very unlikely you're going to kill a patient by giving them CNS prophylaxis. Right. When you give allogeneic transplants, even in best case scenario, with a fit patient, treatment-related mortality is 10 to 20%, meaning you are going to, I'm going to say it like this because this is true, kill the patient. You may kill a patient with your treatment modality who is otherwise already cured. Like, if you're a transplanter and that decision doesn't make you feel really uneasy about everything, and again, I'm not calling on anyone. I'm always very impressed how cavalier some of my colleagues are at recommending transplant when what I just said, in the best case scenario, you will kill 10 to 20% of patients with that procedure. And some of them may already be cured. Can you fathom giving someone a therapy that could kill them when they're already cured? Like, that to me is a huge deal. And even if the patient doesn't die from it, there's huge morbidity associated with the procedure, lifelong complications, GVHD, secondary cancers. It's just a huge deal. As many have pointed out, if allogeneic transplant was a drug that had to go through the FDA, no way on earth would the FDA approve allogeneic transplant. So I've always been torn with that. I have had many patients where I do consolidate, because the question that I have is, and what we really need to know is, if you're going to take everyone with intermediate risk AML and you consolidate them with HiDAC, I will acknowledge that there will be more relapse. Okay. But if you then take that subgroup that relapses and then give them the allo, so only when they need it, as opposed to giving everyone an allo, will there be a survival advantage? And this, you really need a survival advantage in this. Do you understand what I'm saying?
Yeah, but I mean, there's obviously an inherent assumption in your question that everybody that relapses after HiDAC, you'll be able to salvage them and take them to allo.
I agree.
And
that's
I mean, relapse AML is just an awful disease. It's just,
I agree. And that's always the counter argument. You won't be able to salvage them.
Right.
But I think personally, a stronger argument is, we don't know this for true. And we know for sure allogeneic transplant's a bad thing to have to give to someone.
Yeah.
So
no question.
I actually never had a hard time giving consolidation. Clearly it's if it's a young patient, super fit, good sibling and everything, then there's case by case. And, it's getting a little bit easier. We can follow MRD, but in general, the whole thing's a hard decision. So they did the study finally. They did a randomized study. It took them forever to accrue because of biases by colleagues. This was done in Europe. And they didn't enroll to the power that they wanted to. They had to close it early. But so hats off, they did what they needed. They tried to do the study, and while underpowered, and there were many limitations, and who they called intermediate risk wasn't the best, they show no difference to the approach of allo at relapse versus upfront. And so that adds, although it's not the nail binger, it's not like the answer all, and we're now never going to get that. It adds more fuel to the fire, at least to me, that I think it's okay. And I think other transplanters should feel okay, not condemning everyone with intermediate risk AML to an allogeneic transplant. That was a lot of talking. I hope my thought process made sense. And I think that is the hardest decision I make in allogeneic transplant. I do not like seeing intermediate risk AML. It's tough.
So we're going to move to a topic that is always dear to your heart, myeloma.
Oh, I love myeloma.
Yeah, I mean, that's all I hear you talk about. So what has happened in the world of multiple myeloma in 2021?
Well, I always have to give this disclosure because I don't want to get torn apart on Twitter, which I've been torn apart before. I am not considered the key opinion leader of myeloma. I have not designed a trial for multiple myeloma. I am not a myeloma expert. It represents, though, 20% of my practice as a malignant hematologist. And I do treat patients with multiple myeloma with induction therapy, with transplant, maintenance, and on clinical trials. So I have some insight into the field. And I am a consumer of the multiple myeloma literature, okay? So that's the disclaimer. So God, there's quite a bit in myeloma. To be honest, I don't think, well, I will say practice has changed. It's changed for me. Okay. And we've talked about this on Twitter with a few of my fellow myeloma colleagues who I do some research with. So quads versus triplets. So the standard of care. So let's just take, whenever you're a little bit of teaching, as always, whenever you see a newly diagnosed patient with multiple myeloma, the first thing you need to ask yourselves is, are they transplant eligible or not? That's your first dividing point. And most patients actually are transplant eligible. We can safely do melphalan autologous transplants up to the age of, I don't usually do, 75 to 80 is starting to push it, but there's plenty of data that you can do it in older individuals. And we know for sure that autologous stem cell transplantation prolongs first progression-free survival, amount of MRD negativity, and overall survival. Okay. And we know that for sure. It's safe, it's cheap. So that's the most important thing, is whether they're transplant eligible or not. If they are, they should get a transplant. Where there is some debate and not a right answer is the IFM09 study showed us well that if you get standard induction therapy with RVD and you are transplant eligible, whether you go to transplant upfront or you save it for later, doesn't matter as far as overall survival, but it does matter for first progression-free survival. I hope that point makes sense. So if you value a long first progression-free survival, you should get your transplant up front. But whether if overall survival is your thing and you don't want to go to transplant right away, then getting it later, it doesn't negate your survival. And then I usually do tell my patients it's okay to wait. And one of the arguments to waiting is that maybe 5 years from now, we won't need to do transplant anymore because we'll have better therapy. Although we've been saying that for the last 2 decades and that hasn't been the case. So I tell my patients that. And then one of the arguments for going to transplant up front is, let's get it over with. It's a nice long first remission. And who knows what will happen in 5-10 years. Maybe you'll have something bad happen and you won't be a candidate for the procedure. So none of that's changed. Now, what has changed?
That's not what you would tell them. I hope you didn't tell them something bad will happen to you.
No. But I say things. But this is how I do my, you're witnessing how Papa does some consents. I really go through this stuff with my patients. I present the pros and cons of both sides. And I, of course, make a recommendation. I would love to have another podcast on patient-centered decision-making. The way not to do it, as I've seen, unfortunately, so much is, here's a bunch of options, patient. What do you think? What do you want to do? That's clearly not the way. It's the way you do it is, here's a bunch of options. You value their opinions and matters. You say what you would do, and then you say what you would do, what you think you would do given their shoes, and then you make the decision together. But going back to how my practice has changed. So transplant has not changed. If they're eligible, they still go to transplant. I tend to do most of my transplants up front. Most patients want to just get it over with and have a nice first remission. So now induction therapy. So up until now, we have been doing RVD's basically been the standard triplet. So Revlimid, Velcade, dexamethasone. And although never been head-to-head compared to Cyborg in a randomized phase 3, Cyborg has been compared to other imid-containing regimens with thalidomide and been shown inferior. So RVD is basically what we're giving everyone outside of rare exceptions when they present with renal failure and other issues. And now there have been 2 studies. There's a randomized phase 2 they combined, that looked at DARA RVD versus RVD. Okay, so a CD38 monoclonal antibody versus RVD. And it was better in terms of response, MRD negativity, and all that stuff. And then there was a randomized phase 3 study presented at ASH, which was isatuximab, which is the other CD38 directed monoclonal. And that was combined with RVD, and their endpoint was response rate after 4 cycles of induction. And there was more responses, and I believe, don't quote me, I'm not MRD negativity. I believe there was. So we now have 2 studies, one a randomized phase 3 and one a randomized phase 2, and they're doing the randomized phase 3 with daratumumab as we speak. And again, whether you,
so it's RVD, DARA versus RVD.
Yep, that's a randomized phase 3 in process. The randomized phase 2 they reported at ASH. Okay, and then the randomized phase 3 of isatuximab with RVD was reported at ASH, both showing benefit. So we have a randomized phase 3 and a randomized phase 2, showing that quads with a monoclonal for CD38 is superior to RVD in terms of response rate and MRD negativity. It's too early for survival. Okay. And you know, what I would say is with this data is it's going to be hard now not to give this to my patients. I'm just thinking of myself. It does add toxicity in terms of neutropenias and infections, but it's not a huge amount. And I've given the quad before. It's not like we're adding a chemo. It's a monoclonal. And now that Dara's sub-Q, they don't have to have that pain in the ass infusion that used to take forever. So it's minimally less more of a pain for the patient.
Is there, Aaron, is there a stratification based on high risk versus low risk myeloma based on cytogenetics where you can at least decide that the high risk I would give quad versus?
So they included, and I didn't prepare for this podcast disclosure, not making excuses, but they didn't, all subgroups, I believe, benefited in the, again, subgroups, and we shouldn't really make decisions based off subgroups. That's just for further trials. But the trial as a whole was positive. To be honest, I'll have to look that up, and we should make a little blurb if I'm wrong on that one, because I don't know that with facts. Okay. But most in the myeloma community are, at least from Twitter and commentaries, are saying this is now the standard. And, if you look at those PFS curves with Dara RVD, within a few years follow-up, very few have progressed with Dara RVD in an auto. It is quite promising. And I just think as a patient, I feel like I kind of want to get treatment and have a long super remission, not deal with my myeloma and live with it forever. So I do see value in that first remission. The only argument I have is if you give it all up front and don't have anything to give it relapse, are you being detrimental to their overall survival? I will be very shocked if that's the case. Overall survival still might end up being the same, although we now have other randomized studies with daratumumab in the frontline setting, which I won't go into the details, that have shown. One is the Maya study in transplant ineligible, and then the something with an Al cyclone study with daratumumab in the frontline setting that have shown overall survival advantage giving Dara up front. So I think taking that data in aggregate with fairly incremental increase in toxicity, but not you can't ignore it. I have adopted that approach. Now, where I changed from the studies, they gave everyone, like, I think, Dara, Revlimid maintenance. I will not be giving daratumumab maintenance. That's going to cost a lot of money and make the patient go to the infusion center forever. And we have data from the Cassiopeia study that basically showed that in patients who got Dara up front, who then did not benefit from maintenance if they got it up front. So I'm extrapolating, but I don't want to give Dara forever. So I'm following the approaches. I'm just going to give 4 cycles of Dara RVD. So really only four, a few doses. Well, they get it every week for a little bit. Then no more Dara. They're going to have a much higher response rate, more MRD negativity, do a Mel auto, and then do Rev maintenance. And I will have this discussion with my patient. But that's practice changing for me.
Yeah, no, it is. I think one of the issues, and I'm not really sure what the right answer is. I'm curious, obviously, your opinion, is that the data that showed the benefit of maintenance lenalidomide did not use quadruple therapy in induction. So I guess, it's a relevant question. Once you now have quadruple therapy in induction, which is going to have better response and so on, it makes you wonder, do you still need a couple of years of maintenance? Maybe you do, but I just don't think we know the answer, right? Is it fair?
We don't. And while I've been critical of MRD negativity, they are running adaptive studies, where they're maybe if they're MRD negative, they don't need the Revlimid. I will say, though, if you look at the I don't have all the myeloma. It was the Forte study where they gave everyone KRD induction, and then they ran, and then some got auto and some didn't. And the people who were MRD negative after induction who got auto versus those who didn't, they still did better with the auto. Okay. So that just shows us they're MRD negative, but if we had a better test, they're not MRD negative. And we don't know the answer yet to that. So how I handle Revlimid maintenance and this is how I do with all my patients. Another how I practice in my clinic is, we have reasonable data that Revlimid prolongs overall survival, even though I hate maintenance therapy. I hate the idea of it. And I don't use maintenance therapy for PFS benefits. I use it for overall survival. This is, I think, that need for a maintenance setting. We do have that data and a meta-analysis showing overall survival, but we don't know how long to give Revlimid. So what I give my patients is they start Revlimid. And if Revlimid is causing them no problems and they don't even know they're on the medicine, we continue. But I always ask them, especially when we're a year or two into it, I go, is being on this drug decreasing the quality of your life? Because if you're a year or two into Revlimid and it's greatly decreasing the quality of your life and you're just being on it to be on it, I say it is not worth it because we don't have the data at this point, and I stop it. So I am not shy to stop Revlimid maintenance. I have a low threshold to stop it. I do try to start it in everyone because some patients really don't have any side effects or toxicity. Granted, there's financial toxicity, and that's how I do it. But good point. Maybe now they don't need it. I hope the myeloma people who run the studies look at studies like that where yes, and there are some studies. There's a notable randomized study with a bispecific that is looking at a bispecific versus a triplet. That's amazing. They're taking a 1 versus 3. Like this is where I want to see the field of myeloma go, where we're not pummeling our patients with indefinite therapy and using these new therapies to minimize long-term therapy and maybe save money in the long term.
Anything else in the myeloma world that was pretty impressive in 2021 that caught your attention?
So that's the practice changing. I will say in the real world setting, it's been with Abecma, the BCMA CAR T cell. I'm sorry, it sucks. We haven't been able to. It's like it's awful. It's like a Hunger Games. We have lists of patients to try. No one can get it. The manufacturing has been, we just not been able to give it to patients. So what they were able to do, the studies logistically in the real world has not been possible. And it's not just my center, it's all centers. And this just shows the complexity of this care that I love CAR Ts. They are changing, but we're not there yet with, these are not easy therapies to give, manufacture, administer, and get the patient. And we're seeing that with the BCMA CAR T Abecma that's been approved for myeloma. So I have not been able to even give it on label. Fortunately, we have clinical studies and that we can enroll these patients on. There other CAR Ts in the space that are probably going to be approved shortly. So hopefully that will help the thing. And the other thing I will say is the bispecific data. They're not approved yet, but these are bispecifics for BCMA and the other for CD3. So again, little teaching, these are 2 monoclonal antibodies fused at the FC, the tail portion. It brings the T cell to the cancer cell, in this case, BCMA on myeloma plasma cells. All the phase 1 and phase 2 studies have super impressive response rate as single agents, and they seem pretty durable. In my experience enrolling on these studies, they do work very well in my anecdotal experience. And I suspect these will be approved shortly, at least one of them. And these will basically say, there's never been a role for selinexor in my opinion, or not much of a role for belantamab mafodotin. These bispecifics will basically eliminate the need for those drugs. And also I'll be reaching for those before CAR Ts, I think, in many patients. They're easier to give, and there's no data that one's better than the other. And they seem to have less toxicities than the CAR Ts, although they haven't been compared. So that will be practice changing. I apologize. My kids are crying in the background. This is family life.
I think it's perfect. We've talked about non-Hodgkin lymphoma, including T cell. We've talked about myeloma. We've talked about BMT. Maybe let's just tackle really quick. Anything caught your attention in Hodgkin and in acute myeloid leukemia? I think AML, you mentioned something about AML.
We mentioned AML.
We talked about that. Anything?
Yeah, I will say, can I say what's bad for AML?
Yeah.
I got it. Come on. So, and this is, I don't want to steal from Bernie Marini, who's a pharmacist at UMich, who you should have on this podcast. That guy's a genius.
Introduce us.
Yes, I am a very huge fan. He just listening. I have a crush on you. Sorry, Bernie. Just listening to him talk about hematology and drugs, it's like I learned so much from hearing him. But he's been very critical of the drug oral azacitidine. And the study was published in the New England Journal of Medicine. And I see it in practice being used now. Please do not use it. Let me give you my 5 minutes why you should not use this drug ever. And I want the drug company to contact me because this drug sucks. This study was awful. Any investigator on that study, I plead for you to go on Twitter and say that this study's bad. And this study's bad.
What's the study? Tell us about the study.
So this is the, not Admiral study. It's the New England Journal of Medicine. It was basically, they took patients with AML who got induction, Quasar study.
Okay.
I think it's called that. Sorry. They took patients I know the details though. This was in the New England Journal of Medicine, and they took patients with AML who got induction therapy, so 7+3, okay? And then you had to achieve a remission, okay? And then you had to not be a candidate for an allogeneic transplant.
Okay.
You were allowed to get consolidation therapy, but most didn't get much, like one on average, because you had to be enrolled in the study within 3 months of achieving a complete remission. And the study was so to be randomized to oral azacitidine or placebo. Okay.
Okay. You had to be not eligible.
Basically,
You had to be not eligible for transplant, or your connection is back to a bad connection, Aaron. But okay, we're back. You had to have
so not
So going back to this trial, this was a trial, the Quasar trial was 7-3, and then what?
So 7+3, and then you had to achieve a remission, a CR, so hematologic recovery less than 5% blast, and then you had to be enrolled on the study within 3 months of achieving that complete remission, and you were randomized to either placebo or oral azacitidine. Okay.
Okay.
And so one is the standard of care is high dose ARC, and it's not one cycle, it's like 3 cycles of high dose ARC. We know that. Okay. Most patients in the study didn't get much consolidation, if any. Okay. And they were biased towards not getting much because you had to enroll super fast after achieving a complete remission. So you can see if you've only received 1 dose of high dose ARC and you're an investigator and a spot's come open, you can tell the patient, well, don't get any more high dose ARC. You should enroll in this study of oral azacitidine versus placebo. So that's one problem. And you had to be not transplant eligible. And we'll come back to that in the second. And so then they randomized to oral azacitidine versus placebo. So problem one, not getting standard of care. So what would have been a better study is everyone gets their consolidation ARC, which we know benefits, and then randomized to the oral azacitidine, but they didn't do that. Okay. And then problem number 2 is, what they would do is you would get bone marrows every so often, like every 2 months. Okay. First of all, the punchline of the study, there was a prolongation in overall survival with the oral azacitidine, which I like. I love overall survival. It wasn't much, but prolonged versus placebo. What they did is a marrow every 2 months. So you could have in the placebo group greater than 5% blasts in your bone marrow. That's relapse. It's binary. You either have AML or you don't. Okay. But if you were in the placebo group, you would just get more placebo still. If you were in the oral azacitidine group, you had the option of turning up the oral azacitidine dose. So if you're in the placebo group, well, you didn't know if it was oral AZ or not, so you would turn up the placebo dose. So you could have relapsed AML, okay, and just be turning up placebo, okay? And this happened in a reasonable amount of patients. I went back to the supplement and looked. Like, I'm sorry, I'm going to say it, and I hope I get flack. This is not an ethical study. It is not appropriate to be giving placebo to relapsed AML. We're not dealing with an indolent thing, okay? And so 2 bad things. They didn't get good consolidation, and they're getting placebo for their relapsed AML, okay? And then, yay, you showed a benefit for oral azacitidine. But then if you look, patients who relapse after 7+3 in consolidation, a lot of those patients will then go on to get azacitidine because that's a standard of care. They don't report. Really, I couldn't find it, how many people go on in the control arm to have access to azacitidine. It looks like a lot of them just got like crappy care with Hydrea as supportive care. So poor post-protocol reporting and giving. So this study is 100% not practice changing. It pains me that I see people getting oral azacitidine based off this data. And there's no way on earth it's improving the quality of life of these patients. It's mega expensive. So I just think it's a real bad trial. So that is now in our guidelines. And I've seen it adopted to practice, but if anyone reads the study, that study sucks and should not be given. I hope, and please listen to Bernie from U Michigan has lots to say on this study and does a much more better analysis than I just did in these 5 minutes.
We need to get him on Healthcare Unfiltered. Aaron, this is great. I mean, we talked about a variety of heme-related topics and issues. Any burning abstract or data on your mind from 2021 that you would like to share with folks that are going to be listening to this in 2022?
Yeah, I mean,
By the way, why are you not wearing your Healthcare Unfiltered T-shirt?
I'm sorry, it's in the wash because
Oh,
I have four of them, but I do
okay, good. We need to
I
get
do have a lot. Let me practice changing or things that I'm looking forward to. I am looking forward to more of the mature publications of the BCMA bites and approvals of those agents. I'm still eagerly awaiting the publication. This is I promised I wouldn't go COVID, but there was a randomized trial of selinexor for COVID. Okay, that the CEO and they were all saying this was going to be the fix-all for COVID. I mean, giving someone with COVID selinexor seems like the worst idea in the history of time. But they convinced centers to open this study. And I remember a year and a half ago, they were like they were pleading with me to hear this preclinical data that this is going to be amazing. And I said, just show me in patients it works. Well, they never really published the data, but there was a press release that it failed miserably, selinexor. I'm still waiting, Karyopharm, for you guys to publish that randomized data. I would like to look at it, but fail for selinexor. What else? I know that you're putting me on the spot.
No. We can't cover everything. I mean, I realize we can't cover
there are things I'm looking for. I can't come up off the top of my head.
We can't cover everything in an hour. I think, my idea was, let's just talk about few data that really intrigued you and so on. And I think that we covered quite a bit.
Well, I'm trying to think how else I changed practice. I mean, those were the.
I think you're probably using EPOCH-R for everyone.
Oh, can we talk about that a little bit?
Yeah, you've got a couple of minutes. Let's talk EPOCH-R. Are you using it for anybody?
Yeah, so EPOCH-R, I've now 100% changed my practice. I was still occasionally using it for the rare double hit. So, BCL2 translocation, MYC translocation. I will not give dose-adjusted EPOCH to anyone outside of primary mediastinal B-cell lymphoma, even though I truly think if they ran a randomized study, it probably wouldn't be any better. And I do that now because every single data set we get with dose-adjusted EPOCH, whether it be, phase 1 data showing deaths from induction in a phase 1 DLBCL population, which is pretty scary, to phase 3 data showing increased toxicity, no benefit. And now phase 3 data that was presented at ASH, where they took double hit lymphoma and double expressor lymphoma. And they did EPOCH plus venetoclax versus EPOCH. And they showed that by adding the venetoclax, there was no benefit and there was more death, and they had to halt the study early. It just shows it's not a friendly regimen to adding anything. It's clearly unpleasant. That, to me, it's a no-brainer now not to give that regimen. I hope we don't hear about EPOCH anymore on Twitter or in studies, especially now that we have Polarix data. It's just not. It's just listen. Right, this was an NIH regimen that they came up with it, I think, or the NCI.
Yeah, listen, I mean, you can't.
They tried. Listen, I'm not. They tried. We've now shown it sucks. It's no good. It hurts patients. Can we stop giving it? Thank you.
Well, we probably can't stop, but thanks for trying. All right.
It's bad. It's bad for patients. And it's toxic. How the whole nother talk. How that's the de facto standard of care for HIV-associated lymphoma amazes me to this day that is the standard of care. So we've now studied it in non-HIV in numerous settings and have shown no benefit and added toxicity. Does anyone think in their right mind, if you ran a randomized study in the HIV population, that this regimen would be better? So something unique in that population? If anything, it's going to be even more toxic because yes, we do much better with HIV, but they're on lots of other medications and they tend to have sometimes issues, especially when they're diagnosed with low CD4 counts. So I would love to do that debate. How is that the de facto regimen for HIV? It amazes me. But that's so I don't use it in HIV lymphoma. I mean, in Burkitt's, yes, but in like a standard, I just give them March-up.
Aaron, it's always a pleasure to have you on Healthcare Unfiltered. I think next time I'll probably see you at ASCO Chicago, right?
Don't usually go to ASCO. They tend to, not do too much heme, but I might go.
But it's
I
Chicago.
kind of
Like
want to go. I
Chicago
did have
and
a lot of
June.
fun. Yeah,
Yeah.
I had a lot of fun at ASH. They managed to pull off that conference, I thought, safely. Granted, it was before the Omicron invasion, but to my knowledge, they tested. We all had, it can be done, and there was something, again, there's something nice about being with friends, and like if like I got to see you, Shadi, I got to see,
I
and
know.
it really, I think, it motivated a lot of us who've been, even me, I'm getting a little burned out with the amount of clinical work and all these things and COVID. It was nice. So I'm hopeful the conferences in person, I think, will be a motivational push for the oncology field.
It is. It is going to be in person because we need that for the economy of the city of Chicago.
Yes, my grandfather does turn 101, so that's an
Okay.
excuse to visit him in Chicago.
Yes, and I can't wait to be at the party.
Yes,
Aaron Goodman, Papa Heme on Healthcare Unfiltered. As always, thank you.
thank you.